Hello everyone in CardioMinds channel and welcome to the fourth video in the 2024 ESC Guidelines for Atrial Fibrillation. And today we are discussing the first letter in the care pathway, which is standing for comorbidity and risk factor management. We remember from the second video when we discussed the care pathway, which consists of 4 letters: C standing for comorbidity and risk factor management, A standing for avoid stroke and thromboembolism focusing on anticoagulation, then R standing for reduce symptoms by rate and rhythm control, and the last letter E standing for evaluation and dynamic reassessment. Today we are focusing on C letter, which are the comorbidities accompanying atrial fibrillation, and so their management is part of the AF management. First of all, we need to know that there are multiple comorbidities associated with increasing risk of recurrence and progression of atrial fibrillation. That's why their management is central to the successful care for AF patient. It is not just that, by the way, I need to manage these comorbidities. No, if you omit managing these comorbidities, the patient will not improve, otherwise he will deteriorate. That's why there is a class 1 recommendation clearly that identification and management of risk factors and comorbidities is recommended as an integral part of AF care, which are including hypertension, heart failure, diabetes, obesity, sleep apnea, and lifestyle changes that include physical activity and reducing alcohol intake. Let's start with hypertension, which is one of the commonest comorbidities that accompany atrial fibrillation. In those patients, there is an increased risk for stroke, heart failure, major bleeding, and cardiovascular mortality, especially if the hypertension is not optimally controlled in AF patients. The target systolic blood pressure is usually between 120 to 129 mm mercury, and you will find the same target in the 2024 EACTS guidelines for hypertension. Sometimes we may accept systolic blood pressure less than 140 mm mercury, which is raising the concept of as low as reasonably achievable. That sometime maybe because intensive blood pressure control is poorly tolerated in some patients, especially those with orthostatic hypotension or in frail patients and elderly more than 85 years old. That's why sometimes target systolic less than 140 may be enough. And the target diastolic blood pressure is 70 to 79 mm mercury. That's the optimal control for hypertension. In an individual participant data meta-analysis of 22 randomized trials that reporting baseline atrial fibrillation, each 5 mm decrease in systolic blood pressure reduced the risk of major adverse cardiac events by 9%, with identical effect in those with atrial fibrillation like those in sinus rhythm. And the optimal control, that's why, should be considered as an essential component of treating atrial fibrillation that you need to focus on. So far, there are limited comparative data on some medications that may be superior in prevention of recurrent atrial fibrillation. Most of the data are regarding ACE inhibitors or angiotensin receptor blocker, but so far the evidence is not very strong to favor these medications per se. So the recommendation is clear: class 1 recommendation, of course, for blood pressure lowering treatment in patients with atrial fibrillation and hypertension to reduce recurrence and progression of atrial fibrillation and prevent adverse cardiovascular events. Let's now move to another famous comorbidity in AF patients, which is diabetes mellitus. We need to know that patients with post-diabetes and atrial fibrillation, which represent 25% of the total patients, have a worse prognosis with increased risk of healthcare costs. Risk of thromboembolism is higher in diabetic patients in comparison to non-diabetics, mortality and cardiovascular events, and also increasing the recurrence rate after catheter ablation. In cohort studies, the management of diabetes as part of the comprehensive risk factor management was favorably associated with reduced AF symptoms and burden. Besides, reversal of the type of atrial fibrillation, for example, patient with persistent AF, he turns to paroxysmal AF or no AF, and also improved maintenance of sinus rhythm. This means that the patient spends longer time in sinus rhythm. That's why control of diabetes optimally is very important in AF patient, not just by the way you need to control diabetes. No, it is an integral part. And there are some emerging data on the use of SGLT2 inhibitor and GLP-1 analogues in those patients that may be superior to other antidiabetic medications and may have positive impact on treatment choice in the future. So here the recommendation also is clear. Effective glycemic control is recommended as part of the comprehensive risk factor management in patients with diabetes and atrial fibrillation to reduce burden, recurrence, and progression of atrial fibrillation, nearly the same like the recommendation for hypertension. And of course, needless to say that the target hemoglobin A1C in those patients is the same like in other patients, less than 7%. Now moving to one of the commonest comorbidities in AF patient, and here we need to have much more detailed discussion about the association between heart failure and atrial fibrillation. First of all, during 30 years follow-up in the Framingham cohort, it showed that 57% of those with new onset heart failure had concomitant atrial fibrillation. This means that atrial fibrillation is very common in heart failure, and 37% of those with new onset atrial fibrillation already had heart failure. This represents, of course, a strong correlation between the two diseases. And if we asked ourselves why, it is of course a complex answer, but let's simplify it in multiple cardiovascular and non-cardiovascular conditions that impact the development of both atrial fibrillation and heart failure, leading to the common pathway of atrial cardiomyopathy, which is a key pathology in both diseases. Also, in patients with acute heart failure attending the ER, atrial fibrillation was one of the most prevalent triggering factors of this episode. And if we asked why, of course, the key answer is loss of atrial kick and rapid heart rate, which contribute to pulmonary venous congestion and reduced cardiac output. Moreover, the development of heart failure with atrial fibrillation is associated with twofold increase in the risk of stroke and thromboembolism, even after adequate anticoagulation, beside also 25% higher all-cause mortality. This represents the negative impact of heart failure on patients with atrial fibrillation. Not only that it increases the burden of symptoms, but also it may increase the risk of thromboembolic complications. What is the impact of LV ejection fraction on atrial fibrillation? The general rule that prognosis may be affected by LV ejection fraction, as the rate of mortality is higher with the combination of atrial fibrillation and heart failure with reduced ejection fraction as compared with preserved ejection fraction. This means that the lower the ejection fraction, the higher the rate of mortality. However, rates of stroke and incident heart failure hospitalization were similar regardless of LV ejection fraction. So rate of stroke and heart failure is the same in HFrEF as in HFpEF. So the main recommendation in the management of heart failure in atrial fibrillation that appropriate medical therapy is recommended in all AF patients with heart failure and impaired LV ejection fraction to reduce symptom and or hospitalization and also prevent AF recurrence. This is a class 1 recommendation, and the management of heart failure here is according to the 2023 focus update of the 2021 ESC Guidelines for the diagnosis and treatment of acute and chronic heart failure. So we are treating heart failure the same as in the guidelines as in non-AF patients. And regarding patients with heart failure with mildly reduced ejection fraction and atrial fibrillation, they should be generally treated according to the guidance for HFrEF, the same medications, albeit with limited evidence to date in atrial fibrillation. Another recommendation that diuretics are class 1 recommendation in those with atrial fibrillation and heart failure with congestion in order to reduce the symptoms and facilitate better AF management. In order here, achieving a volemic state facilitates better rate control because you are reducing the sympathetic stimulation and the renin-angiotensin stimulation. This results in better rate control. And regarding GLUT2 inhibitors, they are recommended as a class 1 in patients with heart failure and AF regardless LV ejection fraction, because we know that they have evidence in both HFrEF and HFpEF in order to reduce the risk of hospitalization for heart failure and cardiovascular death. And in pre-specified subgroup data on AF from multiple large trials, it showed that the GLUT2 inhibitors like dapagliflozin, empagliflozin, and sotagliflozin are effective in not just medical treatment for heart failure, but also in improving the prognosis in HFpEF. And we remember this from the 2023 focused update of heart failure guidelines that GLUT2 inhibitors are now class 1 recommendation in HFpEF. The question that raised to all of us in our minds, what about the other anti-failure medications? They don't have any role in patients with heart failure and atrial fibrillation. Shall we use them or not? So far, many older guideline recommended therapies lack specific evidence for benefit in those with coexisting HFrEF and AF. They have strong evidence, of course, in patients with HFrEF. But what about HFrEF and atrial fibrillation? So far, they don't have this strong evidence. For example, there are no trial data available in this context for ACE inhibitors, some conflicting data on ARBs, beta blockers in comparison to placebo did not show significant difference for all-cause mortality in patients with HFrEF with atrial fibrillation. So here we are speaking about patients with coexisting HFrEF and atrial fibrillation in order to avoid any misunderstanding that they do not have evidence in HFrEF. No, I'm speaking about the combination of these two diseases in one patient. However, these drugs have clear proof of safety, so they can be used in those patients, and sometimes there may be other indications for these therapies in patients with AF and HFrEF beyond prognosis. For example, management of comorbidity like hypertension, improving symptoms. For example, beta blockers and digoxin have dual function in those patients for rate control of atrial fibrillation and improving heart failure matrix and reducing hospitalization. So, if they don't have strong evidence for prognostic improvement, this doesn't mean that you shouldn't use them, because so far they have clear proof of safety and they may have other indications. So we can say that the appropriate management of heart failure has the potential to reduce recurrence of atrial fibrillation by reducing adverse atrial and ventricular remodeling. For example, RACE-3 trial showed that the combined management of mild to moderate heart failure with RAS blockers, mineralocorticoid receptor antagonists, statins, and beside also cardiac rehabilitation, all of these increase the maintenance of sinus rhythm on ambulatory monitoring at 12 months, and this benefit was not preserved so far at the 5-year follow-up, although this may be confounded by the lack of ongoing intervention beyond 12 months. That's why so far we still use these medications in those with AF and heart failure. Now let's move to other two risk factors that increase the progression of atrial fibrillation, which are obesity and physical inactivity. Regarding obesity, which means body mass index more than or equal 30 kg per meter square, and being overweight, which means BMI more than 25, both are associated with increased risk of recurrent atrial tachyarrhythmia after AF ablation, with 13% increase for every 5 kg per meter square higher BMI. And on the positive side, weight loss more than or equal 10% in overweight and obese individuals with AF has been associated with reduced symptoms and reduced burden in randomized controlled trial with a target BMI that we encourage the patient to reach is less than 27 kg per meter square. And in some cohort studies, they showed that the degree of weight loss and risk factor management was associated with improvement in maintenance of sinus rhythm in a graded response, improved ablation outcomes, and reversal of the type of atrial fibrillation like we spoke before. So this means that weight loss is integral to the management of atrial fibrillation and to improved outcomes after AF ablation. However, sometimes if the weight loss is not very strong, it may not be beneficial. For example, in the SOURCE AF trial, weight loss of 4% from the baseline body weight over 12 months did not affect ablation outcomes, and in the LEGACY study, weight loss of less than or equal 3% had no impact on AF recurrence. That's why you need to encourage the patient to lose more than 10% of his or her body weight. What about physical inactivity? Usually it is forgotten. Why? Because if the patient BMI is less than 25, we consider this patient that he doesn't have any problem with his body weight. So we need to focus on other comorbidities. But if this patient is physically inactive, this means that he has reduced cardiovascular fitness, which has been associated with increased risk of recurrence of AF after ablation, even if the BMI is less than 25 kg per meter square. This means that better cardiovascular fitness and regular aerobic exercise can improve the AF burden in both middle-aged and elderly patients, reduce the symptoms, and improve maintenance of sinus rhythm, quality of life, and exercise capacity. This raises the concept that you need to encourage the patient to practice regular exercise, not just to lose weight. Even if he has normal weight, he should also or she should also practice regular aerobic exercise. So we have a clear recommendation as a class 1 for weight loss with a target of 10% as a part of comprehensive risk factor management of overweight and obese individuals with AF to reduce the symptoms and AF burden, and of course with more reduction in body weight, the better the outcomes for those patients. And regarding physical inactivity, tailored exercise program is recommended as a class 1 in those patients with paroxysmal or persistent AF to improve cardiorespiratory fitness and reduce AF recurrence. Encourage the patient, for example, for at least 30 minutes per day of moderate aerobic exercise for at least 5 days per week. Is there a rule for bariatric surgery? So far, it is a class 2B that in patients with body mass index more than or equal 40, in this case we consider this patient a morbid obesity, so it may be considered in conjunction with lifestyle change and medical treatment where a rhythm control strategy is planned in order to reduce the recurrence, because this patient, if you scheduled him or her for AF ablation, the problem that the risk of recurrence is very high. That's why bariatric surgery here may play a role. However, observational studies raise the possibility of a no point of no return in terms of benefit of weight loss, but also the possibility that bariatric surgery can improve symptoms and reduce recurrence. Now let's move to one of the most important lifestyle factors that play a role in the recurrence and progression of atrial fibrillation, which is alcohol excess. Needless to say, alcohol consumption increases the risk of adverse events in AF patients like thromboembolism and ischemic stroke. So, risk of stroke is higher in those patients who are usually consuming alcohol in large amounts, and increasing mortality, AF-related hospitalization, and the recurrence of AF after catheter ablation. And in patients receiving oral anticoagulation, there is another problem that alcohol excess is associated with a greater risk of bleeding, either due to poor adherence or sometimes alcohol drug interaction. So not only the risk of embolic complications, but also the risk of bleeding events. Also, we know all that alcohol increases the risk of alcoholic liver disease, and so the risk of variceal bleeding with upper GI bleeding. That's why here with oral anticoagulation there is a great problem that risk of bleeding is much higher. So we can conclude that reducing alcohol intake is associated with reduced risk of thromboembolism and ischemic stroke and reduced risk of recurrence. This highlights the importance of asking your patient about whether he is drinking alcohol or not and what is the amount of alcohol he is consuming. So the recommendation here is that reducing alcohol consumption to less than or equal 3 standard drinks, which is equivalent to about less than or equal 30 grams of alcohol per week. This is much lower limit than the general rule of less than or equal 100 grams of alcohol per week. No, in AF patient, the patient should be encouraged to have much lower consumption of alcohol as part of comprehensive risk factor management to reduce recurrence. Although most of the guidelines speak about reducing alcohol consumption in patients with hypertension or ischemic heart disease, or here patient with atrial fibrillation, you can find in the literature and also here in the full text of the 2024 AF guidelines that abstinence is still associated with much lower risk of AF recurrence. So please encourage your patient to try to stop alcohol. Don't just asking the patient to reduce alcohol, because sometimes this is not achievable, but advise your patient that if you stop alcohol completely, this is associated with more significant reduction in the AF recurrence. And the last comorbidity we are speaking about today is the obstructive sleep apnea. We all know that obstructive sleep apnea is very common in AF patients, especially in overweight or obese patients. Polysomnography or home sleep apnea testing are suggested as screening tools in those patients, which is preferred to the screening questionnaire. So we depend on the polysomnography or the sleep apnea testing. There is an important marker that we all need to know, which is the apnea-hypopnea index, which is used to determine the severity of obstructive sleep apnea, which is calculated as the number of apneic or hypopneic episodes per hour of sleep. Normally it should be less than 5 events, mild disease in case of 5 to less than 15 events, moderate 15 to less than 30, and severe obstructive sleep apnea if there are more than or equal 30 events per 1 hour of sleep. And observational studies suggested that individuals with obstructive sleep apnea not treated with continuous positive airway pressure, famously abbreviated as CPAP therapy, respond poorly to treatment for atrial fibrillation with an increased risk of recurrence after cardioversion or ablation. That's why you need to search for this disease in your patient. Don't just depend that the patient is diagnosed with obstructive sleep apnea, because in most of the cases the patient is not diagnosed and you need to ask him about symptoms of obstructive sleep apnea, and if you suspect it, you need to arrange for polysomnography or sleep apnea testing and measure the apnea-hypopnea index. On the opposite side, patients with obstructive sleep apnea treated adequately with CPAP have lower possibility to develop atrial fibrillation, with a small randomized trial of CPAP versus no therapy showed reversal of atrial remodeling in those patients with moderate obstructive sleep apnea. However, other small trials failed to show a benefit from CPAP therapy on ablation outcomes or post-cardioversion, and the data on cardiovascular mortality benefit of CPAP still inconclusive. And this explains why the management of obstructive sleep apnea as a part of a comprehensive management of risk factors in those patients with AF is still class 2B to reduce recurrence and progression, although we all know that those patients should be advised to use CPAP therapy and this will have an impact on the outcomes after ablation, but so far in the literature the evidence is still weak and need more clinical trials. And the big no that screening for obstructive sleep apnea using just symptom-based questionnaire is not recommended as considered class 3. We need to depend on polysomnography and home sleep apnea testing. So this diagram summarizes what we have discussed today related to management of comorbidities and risk factor. We all know that shared decision making is a key to the AF management. We need to focus on key risk factors and provide information to the patient regarding these risk factors and comorbidity without overloading his mind with a lot of information, and then decide the targets that we need to achieve for each comorbidity. So the class 1 for the integrated management to identify and actively manage all of the risk factors and comorbidity. Regarding hypertension, target systolic from 120 to 129 and target diastolic 70 to 79 mm mercury, and always remember the concept of as low as reasonably achievable, because in some patients we may just be satisfied with systolic less than 140. Regarding heart failure, we need to give optimal heart failure treatment for all patients, and we are focusing here on the diuretics and also SGLT2 inhibitor for all LV ejection fraction ranges. Regarding diabetes, effective glycemic control with diet and medication and target hemoglobin A1C less than or equal 7. Obesity, weight loss program if overweight or obese with target more than or equal 10% weight loss. Sleep apnea class 2B to manage this apnea using CPAP to minimize apneic episode. Regarding physical activity, advise your patient to have a tailored exercise program for regular and vigorous activity, and of course reduce alcohol consumption to 3 or less standard drinks per week equivalent to less than 30 gram, and always advise your patient that abstinence has much better results. So we have reached the end of our video today, and the take-home message that treatment of AF does not only focus on rate control, rhythm control and stroke prevention, and so I did my best for this patient. No, if you do not focus on the comorbidities and you omitted them from the AF management, it is a big failure for both the patient, who will not improve and most probably he will develop recurrence and progression of the atrial fibrillation, and also for you as a doctor, because here the treatment is futile without focusing on the comorbidities. Thank you very much for watching this video, and wait next week for another video in the guidelines of atrial fibrillation.